Gee, I wonder what my resident's doing right now.
Hey, Dr. Jordan.
Dr. Ali, what's happening?
I am doing oral board practice with our real-time examiner.
All right,
Shall we?
let's do it.
Are you ready to begin your test?
I'm ready to begin.
A 64-year-old man with end-stage renal disease on hemodialysis presents to your clinic for evaluation of vascular access. He has a history of diabetes, hypertension, and peripheral vascular disease. He has had multiple failed dialysis catheters in the past, and his most recent tunneled catheter has developed recurrent infections. On exam, his right upper extremity has a well-healed scar in the antecubital fossa, and his left upper extremity has no obvious scars. His pulses are palpable at the brachial and radial arteries bilaterally. He is afebrile. Blood pressure is 140/80. Heart rate is 82. And his labs show a creatinine of 7.2 and a white count of 10. What would you like to do now?
At this point, I would like to obtain a comprehensive evaluation of all of the surgical history he has had for vascular access. I would like to know which veins and which arteries were anastomosed and in which extremity. After that, I would also obtain baseline vein mapping studies, as well as ultrasounds of the arm.
The patient is consented for a left radiocephalic arteriovenous fistula. He is brought to the operating room and placed under regional anesthesia. After making a longitudinal incision at the wrist, you identify the radial artery and cephalic vein. The vein appears somewhat thin-walled, but is patent and distends with a vessel loop. The artery is of good caliber with a palpable pulse. You have obtained proximal and distal control of both vessels. Please describe your next operative steps.
Now that I've obtained proximal and distal control of both vessels, my next step is to begin the anastomosis. I would perform an end-to-side anastomosis, end of the cephalic vein to the side of the radial artery.
On inspection, there are no leaks at the anastomosis, and the suture line appears intact. The arteriotomy is not overly small, and the vein is not kinked or twisted. However, the vein wall appears somewhat thick and does not distend well. After gentle milking and flushing, the thrill remains weak. You are concerned about the adequacy of the outflow. How would you proceed to ensure a functional dialysis access for this patient?
All right, so how'd you do?
Well, I passed, and it's really good. So it tells me my overall score, the topics that we covered, and then it talks about all of the essential attributes from the American Board of Surgery, and grades me on each one of those.
All right, that's how the actual boards are graded. So through those essential attributes.
Yeah,
Did you have any gaps in knowledge?
Yeah, I had gaps in knowledge. I mean, I didn't mention any preoperative assessment for central venous stenosis or cardiac function, which I really should have. It said I had a decent understanding of the access options, troubleshooting, and secondary procedures. And the really nice thing is told me exactly which behind the knife oral board scenario will help me with this, and what to listen to. It told me what to work on, the vascular access scenarios. So I'm definitely going to read up on those, as well as our preoperative assessment.
Yeah. And you have all that detailed commentary there if you want to dig in farther.
Oh yeah, and it's very in depth and brilliant. So
awesome. Yeah. Well, thanks to you and Dr. Swenson for all your work on the simulator. Remember, this is the beta version. We are continually receiving feedback. We're going to fine tune this thing, make it amazing. Dominate the day.
Thank you.